Hi guys, this is your Dr. House of Pelvis. In this video, we'll be discussing on how the fetal physiology is functioning with the HB fetus, that is the fetal hemoglobin. And we'll start with a shocking thing. You know, we have been discussing about the stress that is the fetal hypoxia. But a normal baby lives in a hypoxic environment. Shocking, right? Yes. So the arterial saturation of fetus is only 70%. Now, if I have to go from point A to point B, and the point B, for example, we'll give an example. I need 100 books at point B, 100 books I need at point B. But at a time, I can carry only 10 books. So it's simple. I go 10 times. Right? So, if I have only 70% oxygen saturation here and I need to give it to the periphery and the periphery demand increases, I need to do multiple shuttles. Right? That is the reason why the normal fetal heart rate is around 110 to 160. So, because of the baseline hypoxic environment in itself, the fetal heart rate needs to be at a higher level so that it can, supply the periphery properly. And this 70% oxygen saturation can go as low as 30% when the contraction starts to set in. Understood? Now, how does this hypoxic environment is being managed by the fetus? So this is managed because of a beautiful molecule called as fetal hemoglobin. So this fetal hemoglobin, we all have learned that fetal hemoglobin has increased oxygen carrying capacity. It has increased affinity for oxygen. And it also delivers oxygen at hypoxic tissues. Simple. So, what is the meaning of this? See, whatever oxygen the baby can get is from the mother. And the mother is inspiring, mother's lungs are there. Now, mother's lungs are oxygenating the blood that is coming into the pulmonary circulation. It is going into the left atrium, left ventricle. It is coming to the aorta. It is supplying one of the organs of the mother, that is uterus. And from that organ, through the lacunae sinuses, it is reaching the placenta. And from the placenta, it reaches the umbilical vein, and that reaches the baby. So that is the final, minuscule amount of oxygen that reaches the baby, and that needs to supply a huge another structure, the entire baby and its development. So the baby is already in hypoxic environment right now, and I need to extract as much as possible from the mother. We all have learned the phrase that baby is a parasite, right? So if this is the placenta and it tries to extract as much as oxygen, because this is HbF and this is HB adult, and this does not have very good oxygen holding capacity, so this basically squeezes and pulls out as much as oxygen from the mother. So thereby it gets what it needs, and second, wherever there is hypoxic tissue, it will go and deliver the oxygen in that place. And the fourth thing, this HbF molecule also acts as a buffer in acidosis. So this is mechanism number one. Second, we will be discussing on what is the fetal anatomy that helps the hierarchy of preservation that we have discussed in the previous one. So what is the hierarchy of preservation which I have discussed in the previous video? The first thing that needs to be protected is the heart, because I just need to live first. If I am living good, I need to live with the brain. So to live with the brain, I need to supply blood to the brain. Okay, now I'm living with the brain, I'm talking good, I'm walking good. Then I'll be like, okay, let me urinate also. So third thing will be kidney. Fourth, if I'm urinating, I'm doing all my works good. Fourth thing will be like, I think I can go for a party, I can go for a run, I can go for a jog, I can go for a gym. So then comes the body movement. Right? So I told this is the way it is prevented. I know it is preserved in the body. But the fetal anatomy in itself is oriented in such a way that it is working in such a way that it is always trying to prevent it in this manner. So now how does it work? That's when we go into the anatomy of fetal circulation. So how does the anatomy of fetal circulation happen? Let us draw, this is the placenta. This will be the placenta. From the placenta, okay, we will all draw some basic structures. This will be the liver. This will be the heart. Let us slightly remove this topic so that we can understand better. This will be the heart. And this will be the lungs. Right? And you know the lungs are completely collapsed. In the baby, there is no respiration in the baby. Right, now the circulation starts. So how do we start? The oxygenated blood coming from the placenta comes via the umbilical vein. This is the umbilical vein that will enter into the liver through the ductus venosus. This is the ductus venosus, right? Through the liver. That will enter via the IVC into the right atrium. Right? This is oxygenated blood. And from the right atrium, it will enter into the left atrium via, what is the structure? Foramen ovale. This is foramen ovale. So the first structure that we have discussed was ductus venosus. Second structure is foramen ovale. Good. So now the oxygenated blood has reached the left atrium also. It has reached the left ventricle from left atrium. Then eventually from there it goes into the aorta. So this is the aorta. Right? It will come down and supply. Oxygenated blood goes into the left atrium to the aorta and it supplies. Now, the blood in the right atrium also enters the right ventricle and it tries to go into the pulmonary artery. Right? We know it goes into the pulmonary artery. Right? Here the aorta is anterior, obviously, right? And the pulmonary artery is anteriorly in the left side. Great. So now the blood that enters into the right atrium, oxygenated blood that is coming from the umbilical vein, ductus venosus, right atrium, enters the left atrium, reaches the aorta. Good. Not a big issue. But the foramen ovale is a small opening. But now the right atrial blood entered into the right ventricle, it entered into the pulmonary circulation and it went into a useless space called lung, which is not functional. But here is the magic. Here we have a structure called as, what is the structure? Ductus arteriosus. Ductus arteriosus, which connects the pulmonary artery to the arch of aorta. And distal to the ductus arteriosus is the branch which will be the left carotid artery. So carotid artery obviously supplies the brain. So you know this is a postductal branch. So by this mechanism, whatever blood enters into the pulmonary artery enter into the ductus arteriosus and eventually enter into the arch of aorta, and that will eventually enter into the left subclavian artery. So the left carotid artery. So because of this mechanism, we know now the heart will supply to its own by coronary supply from the aorta. Aorta will have small sinuses which will supply. So heart is preserved first. Good enough. The first organ that is perfused in itself is heart. So heart is well circulated. The second structure, because of ductus arteriosus, the highest amount of oxygenated blood reaches the brain first. So because of which brain is also preserved anatomically. Then comes the third structure. Once it has gone to the brain, if the adequate oxygen is reached the brain, then it reaches the diaphragm, it crosses the diaphragm, and then we have the transverse branch, that is the renal artery, and renal artery supplies the kidney. Just for you to remember, we are in cases of chronically hypoxia, chronically there is a hypoperfusion. It's when the renal blood flow is significantly affected and the urine output decreases. So we will discuss the affection of kidney in chronic hypoxia, and we will not discuss kidney with respect to acute hypoxia, because acute hypoxia does not manifest with change in urine amount. The change in urine amount does not drastically manifest in 1 day or 2 days. So when there is a chronic hypoxia, then we tend to see a change in the urine output. So then comes the body movements. So if I am supplying the brain, if I am supplying the kidney, then it goes to the periphery of the body, then it supplies the muscles and the limbs and everywhere. So that's when I start to move my body. So if I'm having enough blood for my heart, if I'm having enough blood from brain, then kidney, then I supply my body, then I try to move. So this is the normal fetal anatomy that itself is promoting this kind of saving mechanism. So whenever we get a mother who says that my baby is not moving, we actually understand that the mother is entering into the first phase of hypoxia, that it is not moving properly, means it is trying to conserve its body energy to supply to the heart, brain or kidney. So that's why we take those patients very seriously. We admit them, we give them fluids and try to resuscitate the baby and see, we put a non-stress test and see are they having the normal changes that should be there, which we will eventually read in the further videos. So not moving of the decreased perception of fetal movement is a very big factor as an obstetrician. We have all been through that, right? Now this is the mechanism by which the fetal hemoglobin tries to help in the maintaining the fetal oxygenation and surviving the baby despite being in a hypoxic environment. So now going further, we will be discussing what is the final common pathway.